I think I'm mirror imaged.
You ready?
Yep.
3, 2.
Welcome to Season 3 of Boston Congress of Public Health's 4-part miniseries, The Great Health Debates. BCPH is a 501c3 nonprofit organization whose mission and vision is to democratize public health through the lens of social justice and to transcend the traditional boundaries of academia and medicine. BCPH does this by supporting leaders, researchers, and advocates who are committed to social justice, health equity, and evidence-based public health thought. As the country becomes exponentially diverse and interconnected, how do we continue to effectively reduce disparities, and what does this look like? I'm your host, Fatu Bari, a current MPH candidate at NYU and fellow at Boston Congress of Public Health. I'm particularly passionate about global health, health equity, and health disparities. With this season being the promise and peril of cultural competence in healthcare, we will be delving into topics surrounding cultural competency, intersectionality, and responsiveness. This series will highlight the perspectives of health providers, professionals, advocates, researchers, and patients, and their encounters and experiences regarding health disparities, literacy, and equity. Medical gaslighting, a term used to describe an experience where a patient feels invalidated or dismissed by their provider. Although it isn't always intentional, research has shown that people of color, women, older people, disabled, and LGBTQ people are frequently dismissed and invalidated by their providers at a higher rate than their counterparts. What are indicators of medical gaslighting, and how can we address it? Allow me to introduce the panelists for episode 2. First, we have Ms. Tracy Koval. Tracy Koval is an author, artist, and disability advocate. Her mission is to incorporate the creative arts into disability advocacy. Her first book, An Untethered Truth, A Medical Journey, focuses on the importance of why one must advocate for themselves with our broken healthcare system. And next, we have Mr. John Scott. Mr. John D. Scott attended UC Berkeley for his undergraduate and graduated from Stanford Law School. He was a military officer for many years and served as a judge advocate general in the Air Force and Marines. He did several tours as a JAG in Afghanistan, and he also did his MPH at Harvard Chan several years ago. He's also currently a private consultant. Thank you, panelists, for joining us. I'm very excited to have this discussion today. Let's dive right in. Tracy, I'll come to you first.
Okay.
What does medical gaslighting mean?
That's a great question. The way that I've understood medical gaslighting is when a provider does not take you seriously, and ideally is the evidence on imaging and tests do not show what is going on. So when it doesn't show, an answer, what the results are, often they'll say, it's in your head. I don't know what to do. Just do yoga. And leave you stranded. And that's the way I've understood it, both in personal experiences and also in work as well. And it's something that can be very, very damaging to someone. And the longer that you are gaslit, the worse the outcomes end up being. And this is something that occurs throughout every single person has probably encountered it, and it's not talked about enough. So that's kind of my way I would explain it is really you're dismissed and not taken seriously and brushed off.
John, would you like to elaborate on the definition of medical gaslighting?
Well, gosh, I think that was a pretty good definition. I might add just the way I look at medical gaslighting in the medical provider field would be really it's a form of moral hazard that's imposed upon patients. Now, I mean, a basic concept in economics, two basic concepts: adverse selection and moral hazard. Adverse selection, if you take it from the provider's point of view or for the insurance company's point of view, it would usually mean adverse selection would be insurance companies want healthy people, yet only sick people want health insurance. And the moral hazard component of it If you're a provider, it's if you give people health insurance, they're more likely to go skydiving or take up dangerous activities. If you flip the script on that and look at moral hazard from the patient's point of view, moral hazard is really that healthcare providers, at least those providing care in the capitated care compensation system, generally speaking, want to give less care because the less care they provide, the more money they make. So it's kind of it's an incentive system that doesn't really favor the patient, and it incentivizes providers to tell people it's all in your head. You know, you have an injury, you have a medical condition. They'll try to minimize it oftentimes, maybe not consciously, maybe subconsciously, just because the incentives push them to do so.
Yeah, and Tracy, you mentioned medical gaslighting being damaging. I'd like to hear your thoughts about the origins of medical gaslighting. Where does it come from? And if you can be a little specific within certain identities.
Yeah, absolutely. And I hope it's okay that I'll go a little bit into my personal story with it. I think it's very difficult when it comes to women and also different minorities to get that specific help. And the origins, I really think that often providers, you're looking at textbook. And what you're learning in textbook is it must be X, Y, and Z. But often you forget to take a step back and look at it as think outside the box. And a lot of rare conditions, that's what occurs. So with my story is I was born with a bunch of medical conditions that were left untreated until my late 20s that left me as an incomplete paraplegic. And growing up, I had spoken up and said, look, I'm in chronic pain. I was diagnosed with this pain condition, and I would learn years later it never happened. And as I kept getting older, I kept being told it's in your head, it's psychological, lose weight. I was never taken seriously. However, imaging was showing something was very wrong. And it would take until my late 20s when I would get the medical records to actually find out, oh my goodness, they missed something major. And that diagnosis that, was given to me at age 11, the test results and everything never matched up, which was really heartbreaking to hear. And what's very difficult is people don't realize when you have that medical gaslighting and, it has taken so long to get the proper answers, it is damaging on all aspects of someone's life, whether it is their career, their education, finances, housing. And unfortunately, that was something that I experienced. And I think what is the most heartbreaking thing is that in the disability community or in general, if you have medical conditions, you're not given a case manager. You have to figure it out on yourself. My background is social work. And from my experience for advocating for my clients, I now had to learn how to become my own advocate and fight to be taken seriously. And the hardest thing I was ever told on so many occasions was if this was treated in childhood, you would not be in a wheelchair. And that is something that took a very long time when it comes to healing and the other aspects of how does it affect one's mental health and how does it affect, again, your education and career and everything, and the amount of discrimination that occurs when it comes to whether it's people with disabilities. We all know discrimination with various minorities and the amount of lack of resources, which is the most heartbreaking thing. And one of the things I wanted to touch upon is when I was in graduate school for my master's in social work, there was never a discussion about people with disabilities. There was never a discussion of how do you find the resources? What do you do? And that, I think about it now and just it's infuriating to think about. And why was it that I had to use my background? I mean, I'm very blessed and thankful I had that background, but why is it that I was not given anyone to help me? And I now had to navigate and figure this out myself. So I know I went on a tangent, but hopefully that gives kind of a perspective on that lens.
No, what an impactful story. And it brings me to my next question. John, I'd like to come to you. What about the medical field or the healthcare environment do you feel contributes to medical gaslighting, or like you brought up earlier, that unconscious bias or that implicit bias? I'm sorry, I don't think we can hear you, John.
My apologies. Yeah, looking at this, I mean, a few things came to mind. First, just looking at the history. The history shows how our current healthcare system, at least on the HMO side, and certainly on the government side, incentivizes less care. Second, a few names came to mind. Daniel Kahneman for his fast and slow thinking, Gary Becker for his really theories of criminal deterrence back in the 60s, and Michelle Mello. She's looking at a lot of issues with basically with the medical malpractice system, how our current system in the United States is all tort-based. And she's looking at things like, well, no-fault compensation for victims, an administrative claims act system similar to what we had in the military, the FTCA, where if you're injured, you file a one-page form. And yeah, it's just saying you're sorry if you're a physician who harmed somebody, admitting fault. So to go into these really quickly, in terms of the history, how should I say this? It's always been about making money in the United States. I mean, Eisenhower, after World War II, Eisenhower wanted to get universal health care for all. It didn't quite go through because those in power wanted to make sure they kept making money. In 73, Edgar Kaiser, who was running Kaiser Permanente at the time, he sent his right-hand person, John Ehrlichman, to meet with President Nixon. And the goal was to lobby for more money for HMOs. It resulted in the HMO Act of 1973. That basically said that if you have more than 25 employees in your business, you have to offer them an HMO option for healthcare. And it paid out about, I don't know, like $375 million just to promote HMOs. But the basic argument he made to Nixon was the less care we provide, the more money we make. And that ethos, the less care we provide, the more money we make in capitated care, kind of spills over into government because if you're a government physician, you're evaluated based on metrics. And the metrics are, do you have healthier patients? I have a friend who works at the VA, and I was advised by this friend of mine that physicians were compensated or given bonuses based upon the vital signs of their patients. And if all of your patients had good vital signs, you received a bonus. Now, it's not something the doctors could do anything about. So a lot of the doctors just falsified the records, falsified the vital signs, because the incentives were there. Now you hear that and you think, well, doctors are awesome people. Why would they do this? And to answer that question, you kind of get into Daniel Kahneman's work on fast and slow thinking. And what he basically said was, there's fast thinking where you take the time where you don't take the time, where you're acting just reactively because you want the bonus, because this is the way it's always been done. Because as Ms. Koval said, when doctors evaluate a problem, there's an incentive to look for horses, not zebras, to just say, what's the obvious answer? That must be it. And if the patient says otherwise, the patient says, I've been living in my body my entire life. The doctor has maybe 15 minutes to evaluate a chart. The patient might know more. Doctors don't want to see that. They want to think the simple answer. So that's fast thinking. Slow thinking is more like, I don't know if you're a Ted Lasso fan, be curious, not judgmental. It's taking the time, stepping back, doing the kind of analysis you can't do while driving, if that makes sense. Actually taking the time to really evaluate the evidence, listen to your patient, do what needs to be done. And a lot of times the problem here is the incentives all push the doctor to not do that. And I don't know, two useful concepts here for medical care. Once you understand the incentive is less care equals more money, at least if you're not doing fee for service. You look at adverse selection, which is just an example that was given by a professor in health and economics at UC Berkeley, was that the first Kaiser building had its enrollment office on the 6th floor of a building with no elevator. So if you wanted to sign up for Kaiser Healthcare at the time, you had to be strong enough to climb 6 flights of stairs. That's adverse selection. They only want the healthiest people because they provide the best low cost. I'm probably going too fast, but moral hazard, the idea with moral hazard is just, if you're a healthcare provider, they like to say, well, people get health insurance, they want to take up motorcycle racing and skydiving. The reality of moral hazard is, the flip side of it is, if you're a physician and you're compensated based upon providing less care to a capitated client, you're more likely to gaslight them. You're more likely to tell them there's nothing wrong with you, it's all in your head. You're also going to probably throw up as many roadblocks as you can to them getting care, like, ambiguous compensation. If maybe it's a PPO, you're not sure if it covers the cost of your care. High deductibles, high co-payments, things of that nature. But that would be the moral hazard on this side. And I don't know, I'm probably talking too much, but the big thought I had was, it's really an access to care issue, and it's an access to justice issue. If you're a physician, this gets into Gary Becker's work on criminology. Basically, you're going to look at this situation and you're going to say, who can I not provide care to, still get the bonus, and not worry about any kind of repercussions, any kind of recourse? And Gary Becker's work on criminology in 1968, it was all about deterrence and how do you deter bad behavior. And he said, basically, you have to try to look at the severity of punishment, the certainty of punishment, and the speed with which punishment occurs if you want to deter bad behavior. Mm-hmm. He was drawing on the works of Becker and Bentham, but basically he said, it's cost-benefit analysis. Criminals do a cost-benefit analysis in their head before they go commit a crime. If a doctor's going to gaslight someone, and they're not just doing it because they're doing it subconsciously, as Kahneman would say, if they're actually doing the calculation and thinking, I want my bonus, but I don't want a medical malpractice case against me, they're probably going to look over the client and say, can I get away with not providing care to this client without risking maybe a complaint against my license, a medical malpractice suit? And unfortunately, in the United States, that's about all you have in terms of recourse against a physician, unless you have gross negligence where you might go into criminal. But really, it's about malpractice suits by tort. And those are extremely difficult for most people to bring against the doctor. They're very expensive. And I'll stop there. I'm sorry.
Mr. Scott, is it okay if I add on to a little bit of something you said?
Please do.
I'm so glad you touched about the bonus part, because I think a lot of people don't realize that providers will also get paid extra if they push a spinal cord stimulator on someone, and they will not explain how it fully can damage someone. So they're not dealing with the whole circumstance. They're putting a Band-Aid on it. And there's certain things with medications and procedures. So I think that's another part that a lot of people don't really think about, but exactly like you said, it's that bonus and whatnot. So that was something I really wanted to add into with that.
Interesting point, both John and Tracy. Tracy, I'd like to stay here because you've stated something very interesting. Along with these issues, these medical issues that patients are dealing with, and then their interactions with their provider, as well as the lack of resources, what repercussions and what effects does this have on the patient?
That is a great question and a loaded question. That's amazing. So I think the best way to say it is it affects your entire life. It affects, resources of how do you survive financially? A lot of people, how do you hold a job if you're dealing with extensive medical situations? Again, we all know our healthcare system is so broken. And like Mr. Scott said about, doctors are given 15 minutes, and how is it that you can, meet with the patient and figure everything out in 15 minutes? That's really difficult with that. It also affects someone with their mental health. The statistics for suicide is 703 3,000 people per year pass by suicide. And that's a major issue when it comes to, there's a lot of areas where suicide comes into play, but when someone has been medically gaslit, they now are starting to question, no one believes me. And, am I making this up? And then starting to realize, okay, hang on. So now it can now affect your education. And unfortunately, there's only so much that can be done under the Americans with Disability Acts. You are protected from kindergarten to 12th grade. Once you get into college for your bachelor's, instead of having an individualized education plan, it now changes to a 504. So there's only so many accommodations that they can do, and it's up to the school's discretion on what they choose to do. When you do a further degree, so again, master's in social work that I was working on, the school had said to me when I was in my last year of school is when my health deteriorated and everything. I had to take a medical leave. I was in my last year, 4 courses left. And I went to the dean and she said, you cannot finish your degree unless you start retaking courses. And I started saying every ADA law. And she said, this has nothing to do with the ADA. And that it was actually under the National Association for Social Work Boards. And the hardest decision I ever had to make was walking away from a degree that I had worked so hard for. So now that goes back into career. Okay, so I'm not able to finish my master's degree. And looking at other schools, they're saying to me, hey, we're not going to take a lot of your classes, even though they're pretty much the same in all states. You now have to restart taking more courses and repeat them. Okay, so if I'm planning on pursuing social work, how can I do that if I have now been told, I'm sorry, you cannot finish your education, restart it? And unfortunately, the university that I was at would not accommodate people with disabilities. Where, for example, one person in one of my classes was in a power chair. What she asked disability services was accommodations where she needed someone to photocopy notes or readings, and the disability, because she couldn't reach it, and disability services said, no, we are not going to do that. And unfortunately, she had to leave the program. So it's absolutely mind-blowing and disgusting for how much discrimination occurs when it comes to the education and career. Again, that financial aspect, getting on Social Security, whether it's SSI or SSDI, is quite a fight. And especially because there are so many people that abuse it. So the people who truly need it, it's even more of a fight. And it can take a minimum up to a year just to meet with a judge if your appeals do not go through. And unfortunately, the younger you are, the harder it is to get on. So that's a big area when it comes to that. The repercussions of mental health, I think many people don't think about medical trauma, and that is a very real thing, especially when you're medically gaslit. And that is something that I have had to overcome and gone to my own therapy for, which, side note, everyone should get a therapist. It's the strongest thing someone can do is take care of their mental health. And it takes a long time to be able to move forward and not allow that whatever misdiagnosis consume you, which is easier said than done. Housing, the repercussions for that, there is such limited housing when it comes to someone with a disability and accommodation. So Section 8 housing, there is minimal housing for someone who may be in a chair or someone who, has a walker. I think another aspect that people don't really realize is home modifications. Insurance won't cover anything. So for example, I have a 50-foot ramp in my backyard so I can go outside and play with my dogs. That was out of pocket. The only thing health insurance would cover was I had to have a doctor's note proving that I had a disability just so we can get the sales tax covered. Other than that, they will not cover anything. When it comes to bathroom things that you need, maybe it's a grab bar, maybe it's, anti-slip things, maybe, various things, they're not going to cover it. You're on your own, which is the most heartbreaking thing. And this also goes back to financial aspects. Okay, if you're now struggling to find a home and you're on the Section 8 list, or you're interested buying a home, okay, you got to look into how much is it going to cost to modify the house? What options do you have that have ranches in it? And for example, we had a contractor come in. I need a new ramp. They said it's between $10,000 to $20,000 for that. Again, insurance won't cover that. And the same thing goes with one of those chair lifts. If it would go like to the top of the stairs all the way down, that is $10,000 that you have to pay out of pocket. And it is very heartbreaking when it comes to this. And it's something that I don't wish anyone should ever have to experience. And there's such a lack of resources. What is helpful, and I know Mr. Scott can definitely speak more about it, from the research I've seen, there are grants and scholarships more for veterans than there are for people with disabilities. So I know I've just spoken a lot of territory, but I think that's kind of the synopsis of everything. And I think the biggest thing is when you go through a life-altering situation and there is that misdiagnosis and medical gaslighting, where do you go now? How do you restart your life? And I did not realize I was going to have to change career paths until I became an incomplete paraplegic, which is, there is a lot of spinal cord damage. So my spinal cord is not fully severed, thank goodness. So my legs can move a little bit, but I can't really feel anything. But for other people who have a complete spinal cord injury, the spinal cord is completely severed. So that becomes even more harder when it comes to that.
Mr. Scott, would you like to elaborate more about the veteran perspective that Tracy just brought up, and also maybe some of the legal and policy perspectives?
Yes, I just like to agree with a lot of what Tracy brought up. One thing on the VA side, I mean, if you're granted a reasonable disability rating as a veteran, you can get access to more resources. Well, at least it's easier, I would say, than it is from the Social Security side of the equation. But getting even a reasonable disability rating as a veteran, it's an uphill battle. They make it as difficult as possible. You go to a compensation and pension, a C&P evaluation, and again, the physicians are compensated, they're given bonuses anyway, to find reasons not to give you a higher disability rating. So the incentives are all pretty inverted. To do it effectively, you almost need an advocate, unless you're an attorney or pretty experienced in the area. And the advocate takes 20% of whatever your award is, at least off the top. That always seemed kind of strange to me. I've helped a lot of people with that stuff, but I've done it for free. But just that aspect of the equation is difficult. The fact that the VA, that the Department of Defense, doesn't take your medical records from your time on active duty and just immediately transfer it to the VA. I mean, when I was coming out, they hand you your medical records and say, make sure you take these paper records over to the VA, and the VA would invariably lose them. So you better make copies. That was the running, advice at the time. So the upshot is we're kind of in a for-profit system in the United States. If we were operating, under a veil of ignorance, like John Walls would recommend, in other words, say that if you knew you were going to be born on planet Earth as a human, you didn't know what position you'd occupy, what would you want the world or your country to look like? Most rational people would say, I'd like my country to look something like Scandinavian countries or New Zealand, or one of these places that has universal health care, subsidizes education, takes care of their veterans, takes care of their sick people, more or less looks after their people. Most rational folks, if they didn't know whether they'd be born a pauper or a prince, would say that's how I'd like my country to look. Our country isn't really structured that way. On the VA side, once you're injured, they kind of look at you as a sled dog that can no longer pull the sled. So they try to give you as little as possible unless you fight hard for it. And even then, it's an uphill battle. On the medical side, same thing. I think gaslighting is just the way HMOs are trying to maximize their profits, and that government healthcare agencies, whether it's the Bureau of Indian Affairs or the VA or Social Security or Medicare, Medicaid, I mean, they're all looking for ways to maximize profit. As Tracy mentioned, even in terms of medical devices and drugs, I mean, there was a red book. Well, it was called the Red Book, but it basically gave the recommended reimbursement rates for drugs. And physicians would always, it was a case we did a long time ago, but it was basically, we found that physicians would tend to overprescribe the drugs for which they receive greater compensation. In other words, the differential between the actual cost they paid after they received their discounts from the pharma companies and the reimbursement rate for state Medicaid. They'd want to, if the gap was big and they got a lot of profit out of prescribing it, they'd overprescribe whatever it was. As far as the legal aspects of this, I'd say it's an access to justice issue. I still would. And I'd say our current system of medical malpractice, it's not geared toward benefiting anyone who's injured by a physician. It's geared toward benefiting expert witnesses, lawyers, 3-judge arbitration panels, even your court reporter, all the middle people. But you're talking about a 50%, 60% dead weight loss by the time you're done in most cases. Going back to Becker, he'd say basically our current system of medical malpractice does a lousy job of compensating the victims, a lousy job of deterrence, because most cases are settled in binding arbitration where there's no public record that a physician did something wrong to someone. It's just paid out of insurance. In terms of the compensation aspect of it, most of the money goes to the attorney. And most people, the thing that, I'll end with this, but the thing that I think a lot of folks don't understand about medical malpractice is the vast majority of people don't ever get an attorney to represent them. And the reason for this is the way the cost structure of medical malpractice insurance is, if you're an attorney and you're doing medical malpractice, you've got to front load all the costs involved in proving up a medical malpractice case. So you've got to prove breach of standard of care. Well, to do that, you have to get an expert witness who's a physician, usually in the same field, and they want to charge $1,000 an hour for their testimony. Then you've got to prove, what was the lifetime cost of this injury, and there you have to hire an economist. They're $800 an hour, let's say, and they want to interview the victim and say, they want a young victim because that increases the time frame. They want someone who's educated because they would have had a good career had this event not cut their career short. They want to hear, again, clear causation, clear breach of standard of care, a lot of meds, a lot of things required. In other words, they're looking for those uniform clients, or unicorns, I should say, people who hit all the metrics for a massive award. And if you've been injured by a physician and you're a little bit older, or the breach of standard of care is not as absolutely clear, or the damage award doesn't look like it's going to be as big, most attorneys don't want to take you on because they know they have to front load, let's say $80,000 to hire all the medical experts. They've got to pay that 3-judge arbitration panel. They've got to hire probably a court reporter. They've got to do all those depositions. So they're thinking, I'm not going to front load that much money unless I'm absolutely certain I'm going to get it back in the form of a big award. So if you're hurt by a physician, I think the metric was around 3% of people who are injured by physicians actually get compensation under the Med-Mal system. This tort system, it's good for attorneys. It's good for the people in the middle. It's not good for the victim. So you want to look at reforming that if you can.
It's very interesting, John. And I kind of want you to elaborate a little more about the VA system. Have you gone through the VA system, and what was that like? And can you let us know if there was any medical gaslighting prevalent?
Sure. When I got out of the military, well, it's a long story, but I hesitated going back to the VA because in the Marine Corps, you don't want to be what they call a sick bay commando. So, you have a stress fracture, you run on it. You have injuries, you just keep going. You're sick, you just shut up and color. You do what you're supposed to do. That was kind of the ethos anyway. So I didn't really want to apply, but initially I was talking to just apply. And I sent them the medical records I have. I think they lost my medical records 6 times. Was the total. So it's a good thing I made copies. They finally awarded me a really, really small award. And I went to their CMP evaluation, and I was there with my significant other. And the CMP physician, my injury was mostly my lower extremities. The CMP physician looked over my chest and said, "Oh, you have a nice chest. You must work out or something." My girlfriend's looking at this person like, "What the hell is wrong with you? What are you doing?" The surgeries were on his legs, not his chest. What are you doing? But the incentive there from the first evaluation was their goal is to say everything's fine. There's no problem here. I went to National Association of Veterans Advocates. Well, there was basically a conference. I met some guys that served within Afghanistan. They said, "John, what the heck are you doing? Here's how you do it. Here's the metrics for it." I reapplied and received a much more favorable outcome. But I kind of took the gloves off when I reapplied. And the number one thing I did was get my own medical expert who evaluated me, not from the VA's perspective, not from the VA's interest, but just from my interest. So I would say anyone going through the VA system, it's laughable. They don't just transfer your medical records electronically from the military to the VA. It would cut down a lot of the administrative issues. And they certainly have a symmetry of ability to do so over an individual veteran, especially a veteran who's injured. But the incentives there are still a bit wrong. Their goal is to not give out care and to find ways not to give out care if they can avoid it. Their goal is to save money. It's how government agencies are organized. I mean, they spend money on furniture so they don't have their budget reduced, but at the same time, they're focused on keeping their metrics high. And the metrics are we've served this many people, 10,000 people, let's say, and we've done it at this low cost per person. We must be very efficient. We must be doing a really good job. And that's not always great for veterans. But yeah, the VA, nonetheless, I'll say they still treat veterans better than they do the general public with respect to disability law. I'm not sure if I'm helping here, but
Oh, absolutely.
but
And I
it
know
is-
we've
it's-
been. Go ahead. I'm sorry.
No, I just say it's a challenge, and I think it's a reason why, when I mentioned Michelle Mello earlier, I mean, she looked at administrative claims. Now, the thing is, if you're in the military, if you're an active duty military member, the rule was always your ferry's barred. In other words, in my case, I had a physician after a deployment supposed to do a little smoothing down of a knee joint. He more or less chopped on my leg for 3 hours, and I told me I'll never run again after that. And I'm like, well, I ran 10 miles on Saturday. What are we talking about here? So that was kind of not great. I had really not much recourse for that at all, because if you're an active duty service member, you're considered military property. By contrast, if you're family of a service member, if a spouse or a child of a service member is injured by a physician, you do have the option of the Federal Tort Claims Act, whereby you file a simple form. An administrator looks at the claim, looks at was there a breach of standard of care, what was the damage, and usually has settlement authority. And I served as one of these folks as an extra duty as a JAG, where maybe I had a settlement authority of $100,000, and I could just contact someone if you were injured by a physician, and we could get that wrapped up in a few weeks, where we could just cut you a check. And if it was above my settlement authority, I could run it up the chain in maybe $500,000. So it's a more efficient way of getting money to the victim. It's a lot more cost effective than a medical malpractice system we have in the United States. If you look at other countries, I mean, New Zealand, all of Scandinavia, they basically have a no-fault medical injury compensation system. Germany does it for devices and drugs, but Germany also has, criminal actions against physicians who hurt people. So there's a different equation there. But the basic idea with the no-fault compensation system, about 90% of the money goes straight to the victim, and it's much faster, and there is a mark on the physician's record. And our system, by contrast, You know, we lose so much to dead weight loss paying attorneys. I mean, the 3-judge arbitration panel, they're 10 grand a day. And you always have to go for at least 3 to 5 days, you know, of hearings. So they're making money, and they're retired judges who are, you know, they have nice lunches and things, but it's not really helping the victim a whole heck of a lot. So, I mean, I really, as much as most lawyers would want to, you know, injure me for saying this, yeah, I really think the medical malpractice system needs reform. And I think the idea that the only way you can get compensation is finding an attorney willing to take your more or less unicorn-like case, bet $80,000 that they're going to get a good settlement out of it, and spend all this time going to hearings. You might spend 5 years on it. There's just got to be a better system. And if we look to other countries, you know, kind of as with universal health care, they've kind of figured it out. There are several better systems than what we have. But the current system has all the incentives favoring the attorneys, favoring the middle people, favoring the expert witnesses, and not favoring the victims.
Yeah, and John, you mentioned that the medical malpractice sector needs reform. Can you describe what reform it needs and what reform looks like in terms of steps?
I'm not an expert in that field. I have done medical
Okay.
malpractice before.
Yes, but
And
what would you
I've
like
seen
to see? What reform would you like to see from this sector?
Well, I don't think it's rocket science. I really think look to other countries that have better outcomes, that take care of their victims more effectively, that deter specific and general bad behavior more effectively, that get the bad doctors out of the equation more effectively. I think if we just look at those systems and see what they do, it's pretty clear. A big problem with our current medical malpractice system is if you're a Kaiser or any HMO, any large PPO, they always make you agree in a contract of adhesion to binding arbitration. And that means you don't get to go to court with your case. You have to go to arbitration first. Arbitration, again, is a 3-judge panel where you pay the 3 judges, you know, let's say $10,000 per day to listen to your case. And after a few days of listening to it, they come up with a decision and they say, we think this is fair, and it's binding upon you. The downside of it is it's not on a public record. As if you'd gone to court, it would be in a public record that this physician had this lawsuit against him or her for doing this action, for this breach of standard of care. Because of that, I'll just say on ours, we saw the same physicians 10 times in a row, 8, 10 times in a row. We had a spine surgeon who basically paid our rent back then because he just kept crippling people. And he was allowed to continue practicing. That was absurd to me. I was, you know, I think I walked up to him after a hearing and said, good Lord, why don't you just go do dermatology or something? What are you doing spine surgery for? You obviously suck at it, you know? But there's not a means by which you can remove these people from the system if you just stick with binding arbitration. Their insurance premiums go up, but the hospital's paying it. So as long as they're needed, they keep them there. By contrast, if you look at any country with an administrative claims system, or even if you look at the military and the Federal Tort Claims Act system, if we have a physician who, you know, injures people repeatedly, you know, each time it goes on the record when we have a Federal Tort Claims Act claim, and if they do it enough, they're out. You know, they're no longer representing the military as a physician. If you look at other countries that do no fault claim, they keep a clear record of what physicians are unlucky. We're not saying they're bad. We're not saying they're not, you know, well-intentioned good people, but it's sort of like a ship's captain. You want someone who hasn't hit icebergs very often, right? So you don't want people who are unlucky, you know, practicing spine surgery, for example. I just think if we looked at an administrative claim system, if we just looked at even physicians being willing to admit fault, having a little more humility, realizing sometimes there are zebras, it's not all just horses. I mean, especially if you're on an African savanna or something, but I mean, just realizing there are those outliers and having a little more humility. And, you know, like going back to Kahneman and Mark Twain, you know, slow thinking, be curious, not judgmental, you'd probably have a lot better outcomes. I I guess I really just don't understand why we don't look internationally for better examples of countries that provide better care for a lower cost.
Yeah, speaking of reform, Tracy, I'm interested to hear your perspective on implementation strategies and intervention strategies when it comes to combating medical gaslighting, specifically maybe from the provider standpoint.
Yeah, absolutely. There's actually a few things I wanted to add to what Mr. Scott had said, because when it comes to medical malpractice, you know, everything he was bringing up, oh my goodness, I couldn't agree anymore um, with it. When it comes to what I've learned with medical malpractice, when I was trying to pursue a lawsuit, I think it's important for people to know it is not possible to sue a hospital. They have too many attorneys on them. You then have to think about which provider did the most damage to you and caused the most harm, and narrowing that down to it and providing that evidence with it. We also have to remember the statute of limitations. So it is, if I'm correct, 7 years to the date of when that they treated and that misdiagnosis occurred to when is it you actually found out it was the misdiagnosis. So just to give an example, and then I'll go back into the what you had just asked. For my case, I was fighting a lawsuit because it was medical conditions that were left untreated, and again was told if they actually took care of it as a child, I would not be a paraplegic and in a wheelchair. Because there were so many providers involved, it would have been a minimum of $250,000 to litigate my case, because there were so many people involved with all aspects of it. And I met with the top 3 attorneys in Massachusetts, and none of them wanted to be able to put that money forward, which I don't blame them when I look at the hindsight. In terms of one of the providers who caused the most harm out of the care, I had the statute of limitations had exceeded by 2 years. And something else I just kind of wanted to mention, I think often we see things as bad doctors, and there are providers that absolutely cause more harm than good, absolutely. But I think we also have to remember and take a step back that there's always a bad, there's always in any type of occupation, uh, um, there's always going to be an issue with the provider. So that's anywhere. So not only doctors, you're going to find it, politicians, you're going to find it with in the education system, other healthcare aspects and whatnot. And I think that's something that is so important to bring up with that. A great example also that I wanted to, piggyback off of Mr. Scott again is, that idea of a bad doctor. And I think a lot of it is providers take on too much they can handle, and they say they know the condition, but actually don't. So, great example was I had found out in 2019 that my spine had been broken and misaligned since birth. And there was a lot of serious damage, including my spinal cord being tied to my tailbone since birth. And the provider I went to see, and he's not a bad person. I see it more as he took on too much. And I brought up one of the conditions I have. It's a genetic condition called Ehlers-Danlos syndrome, which is rare, but it's actually also considered like their mascot is a zebra, which is kind of like what Mr. Scott was bringing up about, that zebra like analogy with that. And I brought it up and I said, look, how does this affect someone's spine? And because it affects the entire body, and I had just been newly diagnosed with it. And the provider said, it does not affect your spine. He said I'd have no issues. I'd be walking, everything right after surgery. And he did the surgery, and I woke up not being able to feel from the waist down. And that was the hardest thing ever. And I had spoken up and said, I can't feel from the waist down. And the best way I described it was my legs felt like a baby giraffe, or I would joke as like Bambi, like when Bambi was first born. And I spoke up, and no one told the doctor for 3 months, including the rehab I was at. And when I look back to this, and I remember he was mortified when I said, I can't feel from the waist down. How did you guys not know? And I would later learn one of the medical conditions I was born with. You are at extremely high risk of increase of paralysis when you go through any type of spine surgery, which is what happened to me. So he took on too much. He said he understood everything that I had condition wise. However, I woke up unable to feel or walk. So the waist down. So I know that kind of goes off topic of where we are at. I just wanted to kind of piggyback with everything. And remind me, what was the original question you wanted me to, or topic to touch on?
Yeah, so I just wanted you to elaborate a little more on implementation efforts and intervention strategies that maybe you would like to see from the provider standpoint in combating medical gaslighting.
Okay, thank you for repeating that. So I think doctors being honest of, I don't know. And I've always said to providers, and many people will say like they'll be frustrated or think the provider is giving up. The first thing I will say is thank you for being honest with me. So I think that is the biggest thing, is if providers can say, I don't know enough. I don't, this isn't my area. So I think that is a huge thing versus someone whose ego is big, or they want to make a bonus from a medication or a procedure or whatnot. So I think that's a good thing. I think the other thing, there is such a lack of communication with our broken healthcare system. So like that example I gave, the rehab I was at never told the doctor I couldn't feel from the waist down. So I think there really needs to be coordinating of care and communication. I think another aspect would be is, can the provider recommend who may be the better fit for them? And also the aspect of, is that provider willing to educate themselves on the conditions you have? And I think really thinking about the whole aspect of, the patient knows their body best. And again, with our broken healthcare system, a lot of things are textbook, especially Massachusetts, versus in another state, they think differently. So, example is, okay, when it came to the misdiagnoses, one of the biggest ones, Boston says it has to be textbook. So it must show up on imaging that it's there. However, 90% of patients, it doesn't show up on imaging. And I would have to go out of state where it was confirmed by everything of, this is what I actually had. So I think another part would be is the biggest thing is like putting the puzzle pieces together. And again, having that approach of thinking outside the box with it. So I think that is another lens that could be really helpful, is, okay, instead of just saying, this is it, whether it's that black and white, which I think a lot of times happens, it's, okay, how is it we can put this like 1,000-piece jigsaw puzzle together and see, okay, how do we coordinate care? What is it we can do to communicate with that?
Right. And I know we've been having a lively discussion about the origins of medical gaslighting and the repercussions and effects that it has on patients. But I think it's really important before we end this discussion to really talk about what medical gaslighting is to a patient. What are some phrases or indicators of medical gaslighting? How do patients know they're being gaslit? And what can they do from there? Tracy?
Wow, that's a great question and things like that. There's a lot of areas with that, but I think the biggest thing, the red flags are, are they actually taking the time to understand your situation? I think the biggest thing is, did the provider read over your case before you came in? Or the doctor comes in, they're like, okay, I don't know why you're here. So I think that is a huge issue that does occur with that. Of course, like my brain just kind of went everywhere with that in my head. So just trying to collect my thoughts with that. Another thing that is really helpful is to be taken seriously. Unfortunately, there's no way to prevent medical gaslighting. However, there are ways that you can be proactive and think of it as be your own best advocate, not even just that, but be your own case manager. So I always give an example to people of something that was really beneficial. And actually my orthopedic surgeon taught me this, that to put together a folder for whatever provider you're seeing and give them all the information they would need, and print it out and bring it to the appointment to give to the doctor, the resident or PA, and also for yourself to have. And basically, it is giving the doctor a whole synopsis of the situation. So, what is going on? How long has this been going on? Your symptoms? What treatments have you tried? What are your diagnoses? Who diagnosed you with this? What medical providers are treating you? Allergies. Almost like think of when you're going to go see a new provider and then they send you all the paperwork, they mail it to you and then they put it in the chart, but does really anyone read it? Versus you bring your own in, you are ready, set, and prepared and ready to go with it. So I think that is something where often it will take providers, like it will give them a different perspective of, oh wait, they know what they're talking about and they have an agenda of covering A, B, C, D with that. So those would be my thoughts on that. When it comes to red flags, if they start talking about how your results show nothing, they don't know what to do, just send you to PT, red flag. If they're not hearing you when it comes to your questions or concerns, red flag. If they are trying to push a medical device that is not even addressing what you actually need, red flag. Trust your gut, and your gut is always right. I think the other part is anyone who is going to meet with a new provider, do your research and educate. A great thing to do is to go on to healthgrades.com and you can really research, look up any provider, and it will give the reviews from other patients' perspectives with that. So I think that's what I'm going to end on, but also thinking of it as the patient. I think changing wording of absolutely, yes, they're a victim, but if we can change the wording to they're a survivor with it.
John, would you like to comment or add to anything Tracy just mentioned?
I'd just like to agree with everything Tracy just mentioned. And actually, I love the idea of keeping your own medical record folder and giving it out to your physician, to your care providers. I mean, okay, HIPAA things come into play, but really, if you're okay with it, it's a great idea. In terms of looking for providers, it's strange because it's kind of what's their perspective. I mean, the first thing I say is if you have a severe injury, something I didn't do, but if you have a severe injury, and something I've done for a lot of people is I say triangulate. And what I mean by that is ask around. And what I often do is I'll call the East Coast, I'll call the top research places on the East Coast. I can't come to the East Coast, but who do you recommend on the West Coast or the Midwest? And I'll call the Midwest, say, hey, I can't come to the Midwest. Who do you recommend on the coast? I'll call the West Coast and say, who do you recommend on the East Coast and the Midwest? I know if you had to recommend someone out here, who do you think? And And I try to hear the same name a few times. And if I hear the same name 3, 4 times, I'm like, okay, that might be a good place to start. In terms of just perspective, I think why we see so much gaslighting from people who don't have access to justice is just subconsciously. I mean, the doctors are, they're looking at a patient, they're thinking, I have this number of patients that I have to see today. I have this much charting. I have this much work to do. A lot of doctors are burned out. They've just gone through COVID. Just looking at the current time frame, a lot of them are overworked, and they're just trying to get through their list. And so they're kind of running, on autopilot. And if you're not advocating for yourself, they're just going to do what they have to do to get to the next patient oftentimes. So I think, what to look for. Yeah, look at the health grades and make sure they've done their homework. Ask them questions that indicate, have you reviewed my chart, or are you just walking into this cold? The biggest thing is, do they listen? In other words, are they listening? Are they taking time? Are they being reflective? Or are they just pushing a medical device, or telling you have to get this procedure, or telling you have to do it with us? There's no option. Because if they don't recommend other physicians who might be able to provide better care because they just have more expertise in a specific area, if they're not saying, well, here are a number of options we could go through, and presenting those options and listening to what you're saying, they might have interests that aren't closely aligned with your own. I think a big problem here is just the perspective we have. You guys are all familiar with this, but I'll just, hate to beat a dead horse here, but really, we have a short-term perspective in U.S. healthcare. Because of the nature of care we have, if you're in the VA system, or maybe Medicare, Medicaid, maybe less so, but if you're with employer-provided care, you're only on their rolls while you're working for that company. So they just want to spend as little on you as possible and kind of kick that can down the road. And if they think you have a major health issue that they don't have to treat right away, they might be incentivized not to treat it right away. In terms of just another factor, I've got to say incentives are key. And if you're with an organization, if you're with a healthcare provider or an HMO that gives out bonuses for, basically providing less care, you have to be cognizant of that. And I'm not saying you have to go with a different healthcare provider, different healthcare insurance company, but at least be aware of that. Be aware your doctors are humans, and they're motivated by incentives just like you are. And so you might have to push a little bit to get what you want. And you might have to push to get a referral to an outside specialist. Final point I'd note, I guess, I'm not sure if we're at the end of the debate, but at least for this topic, is familiarize yourself with the medical licensing board, because almost every state has a medical licensing board that looks upon complaints against physicians. And if you want to get a physician's complaint, medical malpractice, it's great if you're a unicorn client for an attorney. It's great if you check all the boxes and the attorney can say, if I front this much money, I'm likely to get this much payout, because the attorneys do cost benefit analysis too. But if you just put your records together and send a complaint to the medical licensing board on a given physician, you'll get their attention a lot more. And it goes on their record. And it lets other people know that this physician has a complaint against them. And the doctor's ears perk up quite a bit if you do that to a doctor who harmed you. Whereas with the medical malpractice, the tort system we have in place in this country, you go through that, it's how many years, it's how much expense, and usually there's no mark on their record anyway, at least none that anyone can find, because it's settled in arbitration. You're not necessarily admitting fault. It's just binding arbitration. So yeah, I'd say those are things to think about. But I agree with everything Tracy said, and I love the idea of the notebook and just having a health summary for yourself. That's a great one.
And before we end today, I'd love to come back to you, Tracy, for this question. Earlier, you mentioned that medical gaslighting can get to a point where a patient starts to question themselves and question their own symptoms. So, what do you say to someone who's afraid to go to another provider after being gaslit so much?
I think the biggest thing is you're stronger than you think, and that not every doctor is going to be that person you have met with. I think it's very important when you go into a medical appointment, have someone with you. That is going to be key to make sure there's another set of ears and eyes and be able to jump in and talk about that stuff. Um, that's right now what I can fully think of with that. Um, yeah, that's right now what I can think of with it. But that, as scary as it is, you you matter. In your voice, you are your own best advocate. And another place to actually look for different providers is social media. It's a blessing and a curse. But the blessing is there's actually, if you go on Facebook, there's a lot of support groups. And, join the group and ask, has anyone had a provider in the East Coast, West Coast? What was their experience with it? Who do they recommend? Or saying, okay, I'm in this area. What providers should I stay away from? So the more people you can connect with, the better. And there's actually some websites that will provide a resource directory of all different providers that could be beneficial to that condition. So for example, Ehlers-Danlos syndrome, if you go on to their website and you choose your state, it will actually show up every single provider who is the right person for what you may need. So I think, again, that education is going to be that number one thing. But just reminding yourself, you're not crazy. What you're feeling is real. There will always be a light at the end of the tunnel, and you just got to keep fighting. It's okay to have your bad days, but do not give up.
That's very impactful, Tracy. And before we say goodbye to our panelists, I just want to give the audience a couple of key takeaways from today's conversation. Medical gaslighting is just the first step for many people, especially those with complex health issues. It calls upon providers to be transparent and an increase in communication between health sectors, and for providers to be well equipped, and it's okay for them to say, hey, look, I'm not really familiar. Let me refer you to somebody else. And for patients, know your body, trust yourself, and advocate for yourself. Thank you so much, Tracy and Scott, for this fruitful conversation. And stay tuned for episode 4 of the Great Health Debates. Bye-bye.
Thank you.
Thank you.